fingers are a little corrupted, but doesn't matter. We sort it out. I'll start with the case. This is story of a young lady, 32 years old, presented with history of shortness of breath for last 2 months, which was class 2. Single episode of palpitation resulted in syncope 1 month back. No prior history suggestive of cardiac disorder, infancy in childhood were uneventful. No previous history suggestive of rheumatic fever or infective endocarditis. She is a mother of 2 adolescent children, uneventful pregnancy and labor. So, vitals were essentially normal. Cardiac examination showed there was a loud S1 with a murmur of MR. Cardiomegaly was there. X-ray chest also showed that there was a cardiomegaly with LA and appendage enlargement. Pulmonary artery segments was enlarged. ECG was showing left atrial enlargement, left axis deviation, non-specific STD changes in anterior leads. ASLO was normal, cultures negative, mild hepatomegaly, multiple gallstones. Angio showed normal coronaries. This is essential, the 2D versus color. Now there was a mitral regurgitation which was significant. The mitral leaflets looked thickened, and by and large, with this kind of a mitral pattern which showed that there was a mean gradient of 10 and mitral valve area of 1.3 or thereabout, and essentially a diagnosis of rheumatic heart disease was entertained, and these were the observations in echo. Severe mitral regurgitation, mild mitral stenosis, aortic stenosis was moderate, which was 1.3 centimeters square. Aortic regurgitation was moderate, tricuspid regurgitation was mild, pulmonary artery pressures were significant, and a sinus rhythm was there. So this was the diagnosis which was being entertained: rheumatic heart disease with infective endocarditis and mitral valve prolapse. So what else do we need? Transesophageal echo, 3D, angiography was already done. What I mean by angiography is cardiac catheterization also. So we went ahead with transesophageal echo. Transesophageal echo did pick up the etiological differences. But this was the mitral regurgitation. There was a debate which continued, and few of us disagreed with the diagnosis of rheumatic heart disease, and we did a 3D echo. And lo and behold, when we did a 3D echo, this is what we discovered. Any idea what it is? Left. So perforation, cleft. This is a thing which is not a perforation. Perforation essentially starts from the body. It does not involve usually the orifice. If the orifice is being involved, start thinking in terms of cleft. And this is the reason why this became so important, that this was the orifice. The lady underwent surgery without valve replacement, though she was placed for a valve replacement, and there was a distinct advantage. Though we did make a diagnosis of it, I will not make two bones about it. The house was divided, whether it was cleft or whether it was perforation, but the clinching diagnosis was with 3D, where essentially it was found that this is what it was, that this was a cleft. Perforation spares origin, orifice, by and large. Now this is different views. This is from the LV side, and you flip it and you see it from the LA side, but this is more of a drama. We had picked it up from the LA side to begin with, but if you want to see it again, here they are, LV side and LA side, both of them picked up the diagnosis. And usually the clefts are stenciled borders. Perforations may not be stenciled, and this was proven on surgery that this was the cleft. So all the surgeon had to do was just put 2 stitches, and the lady was spared of a major valve replacement with all the concomitant problems. Now if you look at the clinical impacts of 3D echo,
what was the gradient after surgery?
So gradient after surgery were normal, and the gradients which were there were essentially because of the mitral regurgitation.
Why did it happen?
see some aortic registration and we did see aortic valve area 1.3. Now you can always debate because several times the continuity equations can overestimate aortic stenosis, but the gradients were not too many across the aortic valve and we just left.
One of the conditions in that
No, nothing is fused. So mitral stenosis is not there because if you look at this, this is a cleft and see this? This is opening beautifully, loud and clear. Gradients are secondary to MR.
also look like it was just severe. Just
M-mode, did we do M-mode?
showed mitral and which is gradients.
M-mode, I don't think we would have done.
Gradients.
MR?
Mitral gradients you showed. It looked like there was some MS also. Because had it been only MR, that would have given more of a restrictive kind of continuous wave.
So,
give rise to much weak gradients, but not weak gradients.
so this is an MR which is arising from the center of the cleft, not anterior cleft. So these will behave expectedly differently. Now, if you look at this, this is something which मुश्किल है. Anyway, we go ahead because this was an animation which I really was very keen to show you. I'll show it to you in a different way. I'll show you. No, this one. If you look at this, this is an anatomical correlation where all you have to do is imagine that the heart is created like this, and when you start doing an echo, you'll start seeing only two dimensions, which is something like this. Rest of the things which are anterior and posterior, so the depth perception is entirely lost. And when you start doing a 3D, now you'll start seeing that 3D will start reversing what is true to life. Now this is the clinical impact of 3D, because this is how you want to see it, this is how the surgeon wants to see it, and this is how nature has made heart to be. Now, if you were to make imagination, all of us are echocardiographers, we understand the 3D anatomy, but this is not how we had to begin with. If we were to learn, I would have been happier to learn echo, the 3D route, rather than the 2D route. If you look at this, this is again how valves are. The valves are not two on the top, two at the bottom. They are all four in the same plane. And if you look at this, this is how it looks like. So this is mitral, this is tricuspid, this is aortic, and this is pulmonary. Anybody can tell me what is the relationship of aortic and pulmonary valve with each other? If you look at this, they are all almost in the same plane, because this is the AV groove, and it is always in the AV groove that all four valves arise. But still, there is a little bit of a difference, because as the kid is born, the heart starts to twist. The cardiac tubes, they twist over each other, and the valves, which are essentially supposed to be on the left side, this is what mitral valve is, and if you look at this, it will get converted into a 3D just now, and then you will see that this is more realistic way of looking at it. So this is what the 3D is, and similarly, you can see what the association of aortic valve is. Otherwise, in 2D, you lose that association and relationship of aortic valve. So these are the great advantages of 3D as against 2D. But my question to you is, anybody can tell me what is the association or relationship of aortic valve with pulmonary valve?
Is to the left,
Left.
anterior and superior to the aortic valve. Left anterior and superior to the
Superior.
pulmonary is left,
Left.
anterior and superior to the aortic valve.
So everybody has got it right? the way I have remembered is rib. Aortic, pulmonary is, rib is, aortic is right inferior and posterior. You have got it. Pulmonary is left, anterior and superior. So rib is something which I have remembered. But imagine, as a kid, you know that aortic valve is a left-sided valve. But actually it lies on the right side of pulmonary valve. Pulmonary is supposed to be a right-sided valve. So how did you learn it? We learned it because this is what 3D taught us. Whether it was 3D anatomical, in anatomical dissections, whether it was 3D in MRI or whether it is 3D echo now. Now we realize that pulmonary is the left-sided valve. We will see it again. So this is left-sided valve. This is pulmonary, which is on the right. Pulmonary is on the left. Pulmonary is on the left and aortic is on the right. So this is pulmonary, aortic, tricuspid and mitral. Now it shows. So here we are, that how have we evolved? So we have evolved from 1950s where we developed one-dimensional or MO technique, subsequently introduced Doppler. It was in 70s that 2D cut planes were existing and beautifully so. And it was in early 90s that first time the three-dimensional techniques developed, and now it is like 3D. So from 90s to now, there has been yet another era where they used to do a 3D transesophageal echo. And from 0 to 180 degrees, they would take 90 images every 2 degrees. And these 90 images were stitched over each other. And this used to give us a 3D picture. So what we used to do is sit over one study, acquire 19 images, ask the patient to be quiet, still you get maybe about 5 or 7 or 10 stitch artifacts, but this is how 3D was done. Because live 3D was not available. So these are the aims of emerging technology: complete visualization and comprehensive assessment of cardiac morphology and pathomorphology. To achieve this aim, echo has gone technological evolution over the last few decades. Now this is what it has happened, that earlier based on serial acquisition of 2D images, which were then stitched and combined into 3D data set in an offline reconstruction, which was very cumbersome. It would take for one study maybe a night and then you would just rubbish it because it was no good. Now the new 3D technology is real time with more than 3,000 active elements and is a real revolution. This is what it translates into. This is conventional 2D processing, where the data going and coming back is a limited data and it is a beam focused here. As against this, if you look at this, this is the 3D, and in this 3D, there is a huge big all the 3D, oh my god. It's coming back. By the time it comes back, let me see. So this is where we are, where for all practical purposes, the quantum of rays which are going versus the quantum of rays which are received is huge. So there is, in this, one beam would go and come back, one beam will go, come back. Here there are multiple beams which are going several places, and the elements run into thousands these days. And the quantum of data which is received is processed, and eventually you get a deal of this sort. So let me just play through this only. Let me just play through this only, otherwise we keep getting lost in presentations. Okay, so this is what it does. There is a multi-dimensional focusing, precise control of beam profiling is there. In this multi-directional, there is a beam steering, live 3-time real-time acquisition of imaging, information in discrete 2D planes and or 3D volumes. So there are two ways you do it. One is as Parashar sir was saying, that one is a 3D live, and second is that you acquire the whole 3D volume set and you can keep playing it at home offline. So that is a more precise way of doing things, and you can be more liberal with your data acquisition, and you can be more it's less time consuming. And when, especially when you are doing a 3D TEE, best is to acquire quickly volume data sets, keep it, acquire more, keep them, and then offline you keep sorting it out. It is of importance, live 3D, when you are doing a procedure. Say if you are into a tower, that you are doing a clip. That is the time when you need really 3D, that you go quickly put in the clips, you go into the LA side, see whether there is a leakage, where there is a defect, go into, tell the operator that you need to put one more or it is adequate enough. But in case you want to have precision in evaluation, best is to have a 3D volume data set, sit down and comfortably keep sorting it out over a period of time. So, if you look at this, this is how the world has changed. I'll keep clicking one by one, otherwise they are supposed to play them all together. I just hope. These 3D files are very heavy files, and this is, so big advantage is that you can have a look at it either which ways, anteriorly, posteriorly, and there are certain imaging which you can never imagine in gone. Now, in our area, in our part of this world, papillary muscle is very important. Reason being that several of our patients are rheumatic, and rheumatic does not get limited to valves itself. So there are papillary muscles, there are chordae, and several times the maximum stenosis will not be at the level of valve, it will be at the level of chordae, crowded. And that's the reason why papillary muscles, if you really want to see them well, it is in 3D, that you can see the chords, you can see the papillary muscle. The only problem with 3D is that the frame rates are so low that small structures will get ignored. So if in a 3D TE you can pick up a vegetation which is 2 millimeters to 5 millimeters, in 3D you will not be able to pick it up unless it is 5 millimeters plus. Reason being that your frame rates are low, so your resolution reduces. And this fall of resolution is the thing because of which the world is fighting, and that's the reason why more and more number of matrices are being added so as to improve your resolution. Valvular heart disease is something which we are all very concerned. Mitral stenosis is something which we are very concerned. And if you look at this, this is the mitral valve as it looks from the LV side. More often than not, we are bothered about the LA side of mitral stenosis. And if you look at this, you can really make a good positioning in mitral stenosis. The problem with mitral stenosis, why has 3D become a gold standard despite the fact that it overestimates mitral stenosis? You would be surprised. If the truthful mitral valve area is 1, then from the same area, 3D will record it as 0.9 or 0.8. Reason being that the resolution is poor. When the resolution is poorer, the thickness of the valve becomes more. And when the thickness of the valve becomes more, your area of stenosis becomes lesser. But despite that, 3D has become the gold standard when it comes to echo. Why? Any answers? Reason being that when it comes to precision of finding the maximum stenotic area of the funnel, then in 3D you can really find out that which is the maximum area. This is something which you cannot ignore. In 2D, you go here, it will overestimate the area. You go beyond, it may not do justice for it. So this exact precision location can be done by 3D, and that's the reason why it does. Despite the fact that it overestimates stenosis, it underestimates the area. But despite that, this has become the gold standard because precision of finding the maximum stenotic area can be done with 3D. So this is what I meant, that if you look at this, so the color are corrupted, but this is what the area is. You can really define it well because you can really find out which is the maximum stenotic area.
Sir, it overestimates means compared to what it overestimates?
2D.
Original.
2D. For the same
Very
precise
good
area,
so we cannot compare with that.
for the same precise area, if you cut it at the funnel to funnel, 3D overestimates stenosis because the edges are thicker, overestimates the thickness of the valve.
And
But-
that's why we do it now and explain. Like Philips machine have got explained. Similarly, G machines has got pipelines. You take tip cursor right at the in 3 dimensions echo, the cursor line at the tip of the mitral valve, and that will show you a true area. 3D echo will not be a correct area. 2D echo in 3 dimensions would be the correct area.
So explain is something where you cut any structure and simultaneously you will get a 90 degrees axis of it. And that is what he is saying, that becomes very valuable to identify precisely where you need to measure things, not necessarily stenosis or mitral stenosis, where to identify things, anything for that. So this is what mitral valve evaluation is. You can look at this and you can find out the regurgitated 3D color is something which is at this point of time very imprecisely perfected, but it is useful. This is what our multi-valve involvements would look like. You can, in the same single plane, you can find out aortic regurgitation, you can find out mitral regurgitation, you can find out stenosis, either which ways of big arteries as well. Tricuspid is an Achilles heel for echocardiographies because tricuspid and pulmonary valves are Achilles heels because you cannot see an en-face view of tricuspid. It is the largest area. The valve with the largest area is tricuspid, 8 to 10 centimeters square. But visualization wise, it is the most imprecise because you can't see the end-on view. Till you have this. This is something which is a tricuspid valve and you can see it. This is from the RV side, you can see it from the RA side, and you can see the regurgitations too. And this becomes a better modality for tricuspid valve evaluation because there is nothing. So tricuspid RV has to be really huge that you can put the patient on right lateral and identify and in 2D take a short axis across tricuspid valve. Short axis across tricuspid valve is a struggle with 2D, but it is easy with tricuspid 3D. Cleft, we have already seen that example, I will not go into that. Aortic regurgitation is something which you can see. Unfortunately, when it comes to transthoracic 3D evaluation of aortic valve is still a challenge because it's very far field. And because it's a far field, aortic valve evaluation. So for mitral, For all practical purposes, 3D has become a reasonably good choice with almost gold standard for everything. But for aortic valve, I will not say that this has become the gold standard yet, because visualization is far field. And when it is a far field visualization, then evaluation is most of the times imaginary. These are good pictures, does not mean that you will always get them like this. But this is an Achilles heel, and not only in transthoracic, it is an Achilles heel even for transesophageal, because many a times aortic valve are dubious. In fact, the recommendations are that you must do a very good complete 2D evaluation, even if it is for a bicuspid, because it can give lot of erroneity in 3D. 3D becomes imprecise when you want to see stenciled edges. Stenciled edges are not seen in 3D. So this is aortic regurgitation. Unfortunately for regurgitation, quantification still has to be done in 2D. For aortic stenosis, this doesn't play, so I'll quickly go beyond. Vegetations, if you see vegetations of this sort, which are huge, then there is no confusion. The problem comes with small vegetations. Small vegetations can be missed by 3D. So when you have to make a diagnosis of infective endocarditis, be intuitively dependent on your 2D skills rather than 3D. If you don't see a vegetation on 3D, it does not mean that there is no vegetation. Because the frame rate in a 3D is what, 40, 50. As against this, the frame rate goes to 40s and 50s and 100s in 2D. As against that, the frame rate goes to 1000 plus in M1. So for precise location for small structures, 2D is better than 3D. But you can see, you can make very good analysis. If you look at this, this is from the LV side, LA side. Why is it not from the LV side? Why is this from the LA side? Why am I insisting that this is from the LA side and not from the LV side? Sorry? Anybody? So chordae have not seen one, and you can see some kind of an appendage here, and that's the reason why it is from the LA side. For myocardial hypertrophy, these are very good pictures, though hardly any incremental value has been seen in myocardial hypertrophy, because these are dramatic pictures which can be picked up very beautifully on 3D. And actually, one great advantage of hypertrophic obstructive cardiomyopathy is you really want to find out where is the maximum gradient. Whether the maximum gradient is in LVOT because of systolic anterior motion, or whether it is from mid cavity. Does it make a difference if it is from mid cavity versus LVOT? Sorry? Septal ablation?
Alcohol septal ablation will not be successful if it is mid cavity.
Lovely. So you have to find out whether this SAM is a caudal SAM or whether this SAM is from the anterior mitral leaflet. Systolic anterior motion, if it is from the chordae, then has everybody understood what he is saying? Anybody? Anybody? Please don't go with the confusion. Anybody who has got any confusion? He's made things clear to you? So we have to really know where the precisely, and that can be done well by a 3D. Though the gradients have to be calculated in 2D, of course. Cardiac masses, this is LV cardiac mass. You can see the attachment, and this is something which is dramatic. Again, LV clots versus no LV clots. Again, the problem is that if it is an LV clot of this sort, large, you are comfortable. But many a times these LV clots may not be large as large. These LV clots may not be as dramatic as this, and small LV clots you get this. These are certain dramatic pictures. We had one hydrated cyst, and these are the ones which look very beautiful on a 3D. That's the reason I got them here. So, see that cartwheel kind of a daughter cyst, and these are all pictures of a hydrated cyst. This is a mass which is attached to the tricuspid valve. Many a times you want to know the attachment. If you can see it on a 3D, lovely. You'll be able to see it on a 3D better than 2D, because in 2D you will not get all the dimensions. But if the attachment is very thin, then you might pick it up in 2D and you might not pick it up on 3D. This is something which we did, one of my fellows did a thesis on this, and pre and post valvuloplasty. And you would be surprised actually that when we did this study, we didn't know that what happens to the commissures pre and post. And it was only in 20% cases that we discovered that both the commissures opened up equally. In 80%, there was an eccentric opening, which is expected, which you can pick it up on 2D, but more precisely on a 3D. So if this is post BMB, here it shows better. Here, these are rarer ones where both the commissures open up equally well, but most of the times there is an eccentric opening. So the clinical impact for interventional cardiologists is it is useful before and after mitral valvotomy for various device closures, and useful for right ventricular biopsy in post-cardiac transplant patients. These are impact to an interventional cardiologist. We always do our ASTs under 3D, because when you look at it, you're positioning en-face view of the imparter device cannot be seen in any other view except if you are doing. I'm going to talk about AST maybe this afternoon in a little while. I'll show you some good pictures of that. But if you look at this, this is an implaster device which is now en-face seen here, and you can see the placement, whether it is covered all the edges, it is not covered all the edges, how predictable it is. So these are all. Does the patient need another device? So these are certain things which are very useful. These are, we have done these, but not that it matters too much, but you can see the lead of a pacemaker, and you can see how much of tricuspid regurgitation is. More important than that is that several times the lead would perforate the anteromitoid leaflet, and you never know whether it is because of the, not that it matters because you don't need to do anything for that in any case clinically, but these are certain things which help. VSDs are a bit of a challenge in 3D. Reason being that the trabecula are such that when you keep propping it backwards, you don't know whether it is the trabecula, whether it is the crevices that you have hit, or whether you have hit a VSD. So predictability of VSD in a 3D is only when you document flow through that and you see a defect. If you don't see a flow, but you see only the defect, rest assured this is something which is erroneous. Don't trust that it is a VSD. So VSD is a bit of a challenge, but for all practical purposes, if you can document that there is a flow, then even small VSDs you can pick up well. And here is an example of a small VSD. But if it was not for this small flow, we would have not been able to make it out whether this is truthful VSD or not if we didn't have a 2D. So this is a bit of a challenge in 3D. ASD, you can't live without a 3D, but VSD, the trust factor is still lacking. So these are online analysis and measurements, require them, then you can play, and these gives additional advantages for calculation of ejection fraction, quantifies 3D, regional volumes, ejection fractions. You can calculate distances in 3D, you can calculate ASD or MR or FS, and these are the ones which can really help. No, my prayers didn't work again. I mean, I was just hoping again so that this would kind of work. No. And this hopefully should. No. So this is my last but one slide that it promises to redefine echocardiography, instantly reveal complex anatomy, previously conceived during routine echo, improve assessment of valvular anatomy of pre-surgical planning, increases confidence during interventional procedures, improves assessment of regional and global cardiac function, increased productivity and more confident diagnosis. Now, this is something which is being done, but not yet standardized, and it is not part of our standard protocol. And this is RV functions, but at some point of time, I'm 100% sure that this is going to be the gold standard compared to MR. As of now, RV function evaluation is a bit of a challenge for echocardiographers, especially the volumes, and MR has taken over. So this is my last slide, that 3D echo. There is a bright future ahead, and thank you very much for your patient listening, despite the glitches of my slides. Happy to take any questions.
There is an intracardiac vessel in 3D echo. Is there any particular thing regarding differential diagnosis?
So, differential diagnosis of intra or cardiac space occupying lesion is that you have to differentiate whether it is a tumor, it's a thrombus, or whether it's a vegetation. These are three large things. Go by the history. If there is no history of fever, it is not a vegetation. Thrombus, if in a low pressure chambers like left atrium and right atrium, if there is absence of spontaneous echocardiosis, trust me that you are not looking at a thrombus. Space occupying lesion, you can pick it up, you can pick up attachment, you can pick up the size and shape, but if you expect that 3D echocardiography will replace histopathologist, it will not. But several times in 2D you don't know whether there is something lying in the left atrium and where is the attachment. So if you see that the attachment is at the fossa of Alice side, you are pretty much sure that what you are dealing with is an alemixoma and nothing else. But these are things where 2D, good 2D is a prerequisite for 3D. If you don't get a good 2D, you are not going to make any sensible valuation out of 3D. Rubbish in, rubbish out. If you have rubbish as 2D, you will have rubbish as a 3D.
Apart from 2D and 3D, I think if you give a myocardial contrast echo, if that structure is occupied by that myocardial contrast echo, it means it's a vascular structure. So in that case, possibly vegetation will go away, thrombus will go away. And does not require 3D echo at all.
Okay.
Good two-dimensional echo will be fairly precise. And especially when you use a perfusion kind of images.
So it acts something like you do a coronary angiogram and you find that there is a tumor blush from the circumflex. You know it is a lipid. So this is vascularity versus non-vascular, solid versus.
So in 3 of doing 3D equals circular. The prerequisite is a good 2D image to get a good 3D image.
Obviously.
So what are the scenarios where 3D gives us extra information beyond what, except for volumes, any volumes, and extra what, age, culture.
Like Colonel Prashar said, there are certain views you cannot get in 2D. You can't get a short axis across tricuspid valve in 2D. You can't get, so you can't get. You can't get an in-face view of atrial septum.
Mitral valve.
Mitral valve.
Very simple matter. Everybody wants mitral valve. Forget about ASD, forget about anything. Every one of us want to look at the mitral valve.
Scallops. It is so predictable when you do. You keep doing 3DT and you keep imagining since this is 110, so you are seeing A2 and B2. No. Do a 3D, go into short axis, have your aorta at 11 o'clock or 12 o'clock, see that will most is P1, P2, P3, A1, A2, A3, whichever is the one which is prolapsed. So definitions have improved, but if you think that it is going to replace 2D, as of now, no.
Yesterday was a very good example. 2 days down the line, a patient came, was in atrial fibrillation. She was posted for a knee surgery. Somebody did a 2D echo and they said this is diabetic. Stuck. If there is, you can't do it. We did a just 3-dimensional translucent echo. And we could look at atrial appendage, there was no problem. Still the physician wanted to have a 3-dimensional transesophageal appendage. No plot was there. Many examples are there. I'll show a couple of examples where total change of scenario was done in our patient's management. And this is at your level, not at their level. It's not at physician's level. It's you have to be dogmatically saying this cannot be possible.
The advantage is implemented cardiomyopathy, 3D over
So there was something known as an acoustic densitometry. Acoustic densitometry came as an evolution where they thought that they would replace the Hounsfield units. And if there was something that they could calculate differently, they would be able to say whether it is amyloid or whether it is storage disorders or it was calcification. So 3D was not included. Actually, 3D doesn't pick up calcium so well. So the only thing acoustic densitometry did was that it separated calcium from non-calcium. Rest of the things it was not.
Static cardiomyopathy in doctor diagnosis.
tissue characterization as per this.
Acoustic densitometry did come as a tool for investigation, but it was rejected equally. DD. I don't know whether Ajay remembers or not. We used to do a lot of acoustic densitometry in that era.
Some questions?
For minimum mitral office, there should be LA face view or LV.
You can see it from either side.
It will be better.
Obviously, when we are sitting in LV, because at that time we are able to say both annulus, leaflet, cusp, to be very precise, and then codes. In LA, you will not be able to see that very clearly.
Peak of R in LB, cut it across at the maximum stenotic funnel. Why peak of R? End test. Peak of R, LB, cut it across the maximum stenotic area, rotate it and calculate the area. LA side is important because you are able to see the LA appendage. You are able to see the mitral annular calcification. You are able to see mitral and aortic continuity. LV size for precise orifice area.
Moreover, surgeon will be interested from.
So when the repairs are to be done, then not stenosis, but for repairs, LA side becomes important.
But can spectral tracking be used with 3D echo and can give additional information?
Spectral 3D came, people are working still, loyalists swear by it, but there is nothing concrete which is available. Spectral 3D is expected to be something, but as of now, there is nothing concrete. Loyalist होते हैं ना? I will give you an example of a loyalist. The best way to control resistant hypertension is ablate the renal arteries. Denervation. Renal denervation. One trial came, failed. Second trial came, failed. Still the loyalists say, no. We need to have a catheter which will have a multiple exit points, which will burn, and then it will give you. So the loyalists keep working for things for which they are obsessed. There are several of these frauds which are happening. I'm not saying that 3D spectral tracking is a fraud. We don't have enough data yet. Another very interesting fraud is stem cell or ejection fraction. It increases ejection fraction by 2 to 3% with no survival benefit. But the loyalists keep on working for it. Because that is what their life is. They can't reject it because they have put their stake of their lives in that.
So for mitral collapse,
Come again?
for mitral collapse,
LA. From LA side, because that is how the surgeon sees it. You see it from LA side, but mind it, your aorta should be facing northwards. Wherever your aorta is, you have to twist and turn your images that your aorta is from 11 to 12 of position. And that will give you which is the, sorry? Which scale? H. Mitral valve collapse, LSA.
Takes a LA clot. LA appendage clot. Is 3D echo as accurate as 2D transesophageal? Predictive value.
So, you do a 3D only when you detect a clot in LA appendage. It is not that you find that LA appendage is neat and then you do it 3D. What for? What for are you doing it? So, if you look at, okay, so let me give you some trial. Watch my trial.
If it question 3D vis-a-vis 2D T.
2D T, you will do a 3D T.
No, not 3D.
2D T.
Suppose a person has come to the emergency room and the clinician wants me to have a look at the left atrial appendage to look for a clot because he is interested in cardiopathy. So suppose I do a I mean 3D and find no clot. Is it sensible to do the defibrillation?
No, sir. Recommendations are that you have to do a transesophageal echo to rule out an appendage clot. Because it is too much of a risk that you are taking.
the cropping with 3D sometimes permits you to see the LA appendage beautifully, even with transthoracic.
So in transthoracic, if you
If you can get that.
If you can
if you
get.
can get that.
is configured only with 3D.
P
Transit
is the
space.
gold standard right now.
These are more configured.
3D importance is when you have to put the device. When you have to put watchman device or an ECP device, then it depends on 3D. Because if it is a deeper device versus a shallower device, your choice changes from ECP to watchman device. Similarly, you have to look at how many lobes are there. For that, 3D becomes a little better. Because in 2D, you have to imagine, say if it's a cauliflower shape or whether it's a chicken wing shape, you have to imagine in 2D. But when it comes to 3D, you are pretty much sure that what is the shape of the belly appendage. There it is an important thing. So for people who are into devices, that is yet another loyalist, yet another fraud, L appendage closure, international fraud. I can debate on it. But it doesn't matter, we are all echocardiographers and we don't mind doing echocardiography even if it's for a fraud. So, shall we go ahead with the next one?
What is